introduce Dr. Barbara Brandt. She's our speaker today. I'm Carla Hemiseth, and I coordinate interprofessional faculty development for the Office of Education and the One Health Group. Dr. Brandt is the Associate Vice President for Education in the AHC, and she's the Director of the National Center for Interprofessional Practice and Education. Today, she's going to speak about a recent experiences. One of the 6 members of the Institute of Medicine, they came to name the Academy of Medicine. It is my pleasure to introduce Dr. Barbara Brandt. She's our speaker today. I'm Carla Hemiseth, and I coordinate interprofessional faculty development for the Office of Education and the One Health Group. Dr. Brandt is the Associate Vice President for Education in the AHC, and she's the Director of the National Center for Interprofessional Practice and Education. Today, she's going to speak about a recent experiences. One of the 6 members of the Institute of Medicine, they came to name the Academy of Medicine. They still medicine under the National Academy of Medicine. Okay, all right. So as we know, the IOM, she was one of 6 members of a consensus study group that was charged with looking at available data and information globally to determine the best method for measuring the impact of IPE on patient safety, provider and patient satisfaction, quality of care, community health outcomes, and cost savings. Today, Dr. Brandt's going to address the committee's charge, the work they did, and the findings, and the implications. So welcome, and thank you.
So thanks for coming today and really being interested in what I consider really a seminal report that came out last spring by the Institute of Medicine, which was charged to actually ask the question, does this work? So, and not just to learners, but in the long run to patients and health outcomes. So just a little bit about the background. This, with the explosion of interest in 2 things. One was in December 2010, there was a seminal report in the Lancet journal on integrating health professions education for an interdependent world. I can't remember exactly what the title is, but that was the first real explosion of interest this time around, that health professions education really needs to change. And as a result of that, the Institute of Medicine got involved with many of the people who were authors or co-authors of that seminal piece are members of the IOM. So through that work, and then later the IPEC group, or the Interprofessional Education Collaborative, which is AAMC, the American Association of Colleges of Osteopathic Medicine, American Association of Colleges of Nursing, American Dental Education Association, and the Association of Schools and Programs in Public Health came together to form the IPEC, or Interprofessional Education Collaborative. And there are 4 competencies now for interprofessional collaborative practice. Now, that's given a lot of heartburn to professions who work at this people, but they're coming along. And so there's a lot of conversations across the professions about endorsing those competencies. So as a result, around that time frame, the IOM formed something called the Global Forum on Innovation in Health Professions Education. So it's now up to 60 organizations, and the AMAs at the table and the like, and it's all focused on education. So every year they ask that particular group that pays a lot of money to be at the table on that, what is it that you want to work on? And last year it was, does interprofessional education make any difference? And so this was the title of the charge to a work group, and it was called a FAST Study Committee on Measuring the Impact of Interprofessional Education on Collaborative Practice and Patient Outcomes. So the question was, does this make a difference in the long run on patient outcomes? So this was an unusual committee. Usually they IOM appoints a committee, and they at least take a year and they get to do a lot of study, but this one was literally, it's called a fast track, and it was 6 months. And these are the members of the committee. It was chaired by Malcolm Cox, who most recently, before he retired, was the head of the VA's Office of Academic Affiliation. So all of the VA education programs And others who were on the committee was Janice Kalaganis, who is at Harvard in simulation. Scott Reeves, many of you who do work in this field will recognize as the editor of the Journal of Interprofessional Care. Albert Wu, who is a heavy-duty health services researcher. I think he thought he died and went to hell with all the educators. He is a methodologist supreme, but he knew nothing about education or interprofessional education. So he was really there to keep pushing the methodology. And then Brenda Zerler, who's at the University of Washington, she's quite well known. And then there were these consultants. So this committee, this was our charge. It's an IOM committee will examine the methods needed to measure the impact on IPE on downstream outcomes. So collaborative practice, patient safety, provider, patient satisfaction, quality of care, community health outcomes, and cost savings. And to recommend a range of different approaches based on the best available methodologies that measure the impact on IPE. The committee will identify gaps where further research is needed. So it's a very interesting process. You're given this charge and you can't deviate at all. You must deliver. And so we worked from October 6th last year, and there was a public meeting that Tina Brashears, who's at the University of Virginia, did a lit review and mostly a Cochrane-style review looking at the literature and did a report. But then there were other people who presented in the day. One of them was Stephen Finn, who is the physician who has implemented 900 patient-aligned clinical teams in the VA nationwide. So he's done quite a bit of research on 900 teams, doing comparisons of those teams. And one of the things he can tell you is yes, teams are effective, but it depends. It depends upon where they are, what kind of organizational culture and support that they get. So, okay. So these were after we started on October 6th with the meeting, and we had to submit our report in March. So it was a tremendous amount of work, as you can see, when I get deeper into what we actually did. But these are essentially the key findings of the report. It's that interprofessional education can improve learners' perceptions of interprofessional practice and enhance collaborative knowledge and skills. So after doing a lot of study, there's no question that perception is changed by this type of education. However, establishing a direct cause and effect relationship between interprofessional education and patient population and systems outcomes has proven more difficult. And I'll talk a little bit more about what's the cause of that. And then the lack of a well-established causal relationship between education and health and systems outcomes is not unique to IPE. So one of the things that we went round and round, even in the public meeting, was that should IPE even be held to a higher standard than medical education or other health professions education? And, I tell people the answer is yes, because we're changing a paradigm. And as long as you're changing a paradigm, that means culture change. And people are looking for evidence to make that change. So you'll hear a little bit about the fact that that's what the National Center is focusing on. So other recommendations are to evaluate the impact of IPE on health and systems outcomes. There will need to be committed resources. So one of the things about doing research, educational research, we're always doing it on the fly. It's never adequately resourced. So if we're really going to be serious about investing money in this type of education, there needs to also be investment in the research that needs to follow, and that a mixed methods research approach needs to happen. So one of the things that in the National Center we even are coping with this is people seem to go to, if you don't have a randomized controlled trial, it's not going to mean anything. So a recommendation for the folks who really studied what's out there is it really needs to be a mixed method approach, and it needs to be done by people who know what they're doing. So when possible, include an economic analysis carried out by teams of experts that include educational evaluators, health services researchers, and economists,
along with educators, and others engaged in IPE. So these are the key elements of the report, and you can go on the IOM. You actually can Google this, and it pops up, and it's readily available to reference. So key elements of the report. So you'll look in Appendix A is we did a review of measuring the impact on IPE. So we did an extensive review of the literature. So there are 39 reviews that are out there. The one that has gotten the press over the years has been Scott Reeves. So he and his colleagues have done Cochrane reviews, and they've used something, and I'll be explaining this, called the Kirkpatrick framework that they adapted, that they do Cochrane reviews. And over again, they've published that there is no evidence. And that's the reason they did it, was that they're trying to push into more rigor in research, but in some cases it's actually backfired. So this work is very difficult to do. So as long as you're telling a dean that there's no evidence, or a vice president, that has in the past has meant, okay, we're not going to do it, there's no evidence. But it's been a conundrum about cause and effect of, what comes first, the chicken or the egg. And then we have the paper in there, which is by Tina Bashir and her colleagues. That was the public presentation. We did the synthesis of the IPE reviews, and then a part of this publication, actually these three members of the team wrote a separate report, and it's actually been peer reviewed and published since this release. So 3 conclusions is the more purposeful, well-designed, and thoughtful reported studies are needed to answer key questions about the effectiveness of IPE in improving performance in practice and health and systems outcomes. Another key finding is without purposeful and more comprehensive system of engagement between education and healthcare delivery, evaluating IPE, the impact of IPE interventions on health and systems outcomes will be difficult. So, our model of education, I don't have to tell you, is we educate people in the classroom and then we send them out on rotations. And that's actually rapidly changing. So this, doing 1 month at a time based upon clinical competencies, there are many partnerships starting to develop nationally, and actually new schools opening up around the fact that this alignment between education and practice must become stronger. And it's because of the transforming delivery system. The delivery system needs a different kind of practitioner. They need a different kind of team. And the recognition that they have to retrain graduates if they're not trained in new models of care. So that is very much happening nationally in many parts of the United States. Then having a comprehensive conceptual model would greatly enhance the description and purpose of IPE interventions and their potential impact. Such a model would provide a consistent taxonomy and framework for strengthening the evidence base linking IPE with health and systems outcomes. So I'll be going through this conceptual model. And in the report, we put a glossary out. And for the most part, the glossary is definitions that are already out there. But this consensus building across the professions is very much happening. So again, without this, we can't do quality research and certainly demonstrate the outcomes. So this is how the report is broken down. Chapter 2 is about the lack of alignment between education and practice. And I just had Jill Thistlethwaite do a study based upon what's the global perspective of the National Center. So she interviewed 30 international experts on IPE. And one of the findings is a head scratching about what's this education and practice thing? Why is that so important? And it's because every other country doesn't have the mess that we have in the United States, and that we have this transforming delivery system over here. And often, and even more commonly, education's not at the table or coming together. So globally, this is while we've talked about education and practice or town and gown needing to come together, it's become much more acute since particularly healthcare reform. And then a lack of commonly agreed upon taxonomy and conceptual model linking education interventions to outcomes, and really acknowledging this is a very difficult research environment. The confounding variables in all of this is unbelievable. So, and then inconsistency in study designs and methods and lack of full reporting on the methods employed. So we really looked at the literature, and without that consistency or without researchers who really know how to do rigorous methodologies, you get a mixed bag out there. And for the most part, there's a lot of studies out there, but it's all over the place as far as the rigor of the methodologies. And then it finally ends with chapter 5 on practical solutions. So a little bit about the alignment is that healthcare payers determine the overall shape and function of the system and provide resources for system redesign and innovative practice models. So one of the things that the reality is we've been living in a fee-for-service model, except for the VA, that's, for the most part has been protected or can do some innovative things that many other systems cannot do. The reality is our payer system is changing very rapidly in this country. So Medicare is going on value-based payments or bundle payments or global payments, meaning not the term pay for performance, but literally paying for outcomes. And that is going, so Medicare's first, with the thinking that third-party payers are going to follow very quickly. It's already here in Minnesota to a large extent, but it is, as you go across the country, you're seeing this, and you can see realignment of systems around getting ready for this. So the fact that this is happening is a good sign, and we are seen as taking interprofessional learning more seriously. The research agencies determine the overall shape and direction of research for IPE and collaborative practice. There really isn't a lot of money for this if you only go after the education. But if you start to think more broadly that this is about changing practice and learning, that changes your perspective and potential for getting funded in this area. The credentialing bodies determine the overall shape and composition of the clinical workforce. And I would say right now also, so the driver there is that the creditors are asking for certain things for the most part now in individual schools. What's happening now is nearly every accreditor has written interprofessional or team-based practice and learning into their accreditation standards. So LCME, the nursing program, pharmacy is there. The problem is they haven't come together to determine what they mean together. So we could be running around and one agency accepts one thing and another has a different vision. The good news is these accreditors are now starting to get together and they're starting to come to consensus so that when they come here, and pharmacy is it this week, it's unbelievable how many times interprofessional education is in their standards, but they are coming to consensus about what they're looking for across the professions. Then better alignment requires funders and regulators, strengthening collaborative partnerships between health professions, education, and systems. So a lot of work is also being done in the regulatory, the licensing boards and the like, nationally, conversations. And then better alignment will be fostered by economic incentives and the adoption of competency-based education expectations for accreditation. So again, definitely moving in that direction. But as I look in this room, I'm looking at dentistry, wondering where we fit in this model. Is it oral health or is it dentistry or the like? OT is going through new practice models. So again, all of these conversations are going on nationally in practice with the question, what does that mean for education programs? And frankly, how are we going to regulate and accredit it? So this was my part of the report. And so we came to the conclusion after hearing one presentation by Madeline Schmidt, who's a retired faculty member at the University of Rochester, with John Owens, who's at the University of Virginia, on thinking through outcomes across the learning continuum. So they had actually published, but what they didn't publish is that those outcomes should be linking, that those, what are the competencies should be linking to outcomes. So you can well imagine we fought mightily over this model, and I'll tell you why. So the blue box in the upper left-hand corner is the learning continuum. And one of the important key elements that we decided that we were going to declare, yes, interprofessional education and learning about teams needs to start from day one. So this field is not new. It goes back 40 or 50 years. That has been a major conversation, is where do you start this? And so we declared, every one of us, that you needed to be developing pre-professional students, team competencies or key team identity, along with the professional identity. So we all know that that's not easy to do. That's a commitment that we did make here early on, maybe 5 or 6 years ago. So the tension that we had was what to call these stages, because, you know, one profession calls something residencies, you know, and then you get to the discussion about what the DNP doesn't do this or that. We want to call it this. So we decided to call it foundational education, and that can be defined broadly. Graduate education, big controversy using that term, but what we thought about, particularly as you think of medicine, dentistry, pharmacy, residency programs, but again, it takes different stages, and then continuing professional development. So many professions are moving to that model about thinking about what happens in practice and performance in practice. So what we declared is that while it needs to be introduced early, the amount needs to actually accelerate as we get into practice. Most of the work is working in teams and collaborative interprofessional work. And what really sealed the deal for us was I told you we interviewed Stephen Finn, who could tell you about his 900 teams, give you positive outcomes and not so positive outcomes, and tell you that training does work, but it depends upon the setting. We also interviewed the Vermont Blueprint for Health. So that's a major implementation across the state of teams moving into the community. And so both of those leaders, we talked to them about, well, tell us about the education and training that you provide to implement these teams. And both of them talked a lot about learning by doing and, you know, trial and error or quality improvement. But they really scratched their heads about, well, what formal training works? And so we had asked them specifically about team steps. And one of them said, well, our experiences, that's what takes us away from real learning. And so we then decided there is something here that we need to throw out. And so there's a body of literature that's about workplace learning and informal learning and the value of learning on the job. And that used to be a big strand of research that actually got dumped maybe 15 or 20 years ago. But we're advocating, particularly with some of the new models of maintenance of certification, which has all its controversies in medicine, with thinking about performance, that we need to step up the pace of really understanding how professionals learn and can learn better in practice. So what I want to make abundantly clear is that this committee came down that interprofessional learning needs to happen, and formal and intentional, starting from day one, and needs to be accelerated and increased throughout a lifespan of a professional. So that was a very important declaration for us because it flies in the face of a lot of the interprofessional education literature. We then, if you come down, separated out intermediate or learning outcomes from the distal health systems outcomes. And we looked at all sorts of models that stage a hierarchy of learning outcomes. And, there's a lot of wonderfulness out there. We actually decided that, at least in the interprofessional education literature, this Kirkpatrick model is the one that's used. It's been adapted, and we would stick to it. And so it is reaction. So you do something, how did you like it? This is great. Just a gut reaction to the learning activity. Are we changing attitudes and perspectives or perceptions about teamwork and collaborative practice? Getting to the level that there's actually knowledge and skills that are imparted in this type of learning. So it's not just fuzzy, are we getting along and loving each other? And that we actually are demonstrating collaborative behaviors. So the OSCEs, the simulation and the like, that there is a skill set that can be taught and demonstrated. And then finally, the highest level is performance in practice. And that as we think through, the reason for that is thinking through a curriculum. In that, where does this need to be introduced? How do you introduce it? And the like. And then these are the outcomes that we think can be captured in this model. And I won't go through those, but you see cost efficiencies, that return on investment model. But really realizing that there are definitely enabling and interfering factors. And those have to do with professional culture, institutional organizational culture, workforce policy. So a big deal is understanding scope of practice laws, licensing laws, and the like, not just laws, but how are they implemented in the bylaws of hospitals and health systems. And then finally, the financing policy, or how do people get paid for this work? So a little bit more, the big aha in this committee, and I've talked about most of this, but we call this the reverse megaphone. And the big aha, it didn't hit me as hard as it did Brenda Zerler, who's at the University of Washington. So she's in the School of Nursing. She's a highly regarded both educator and researcher in this area, but she spent most of her time in the curriculum, and this is not unusual, packing it with interprofessional, patient safety, team steps, and the like, and that when students go out into practice, some sort of magic's going to happen. So, not really thinking through or front-loading the beginning of IPE and not thinking through the follow-through of it all. So again, this is, really coming out there and saying, because schools that are implementing this tend to front-load it, that we need to do the reverse megaphone. That not that we shouldn't be having courses and, introducing it, but that we must start paying much more attention on what students and residents and the like are doing in practice. Because without it, it is the hidden curriculum on steroids. So we teach it in the classroom, students don't see it, and it's not going to stick. So I'm going to spend the next 5 minutes maybe, and then we can talk, kind of getting you into the National Center. And I would be more than happy to come back and explain the work that's in the National Center and why we're doing what we're doing. So this is the vision statement, as we believe high-performing teams can improve the experience, outcomes, and costs of care. And that is the triple aim, or the Institute of Healthcare Improvement's triple aim. And again, the literature is really spotty. While everybody's rushing to teams, it depends. It depends upon context, it depends upon what you're working on and the like. And that we are studying and advancing the way stakeholders in health work and learn together. So we very much selected stakeholders in health, and we've moved away from teams of physicians, nurses, pharmacists, and the like, because the movement of incorporating patients into the work, patients and people, patients' families and communities, is going on very forcefully, and that people and patients are becoming members of the team. These are our funders. We do have private funding, and HRSA is a funder of the National Center. Last year, we had somebody from HRSA was here for 3 weeks. It was a really wonderful experience, I might add. So we got a call that they were wondering what we were doing and decided to send an evaluator for 3 weeks. I had to call Pam Webb, Vice President for Sponsored Projects, to say that we had somebody from the federal government was going to be sitting in my office for 3 weeks. So we came out of there with the evaluation strategy, but they also helped us with the language about the National Center because it was in the funding opportunity announcement that we responded to, and that we are to provide leadership, evidence, and resources needed to guide the nation on the use of interprofessional practice and education. And we in the National Center use those terms because we think it's the new IPE. It's not interprofessional education, it's interprofessional practice and education as a way to enhance essentially the triple aim. So the experience of healthcare, improving population health, and reducing the overall cost of care. This is our, actually I saw that earlier. This is the sort of like the icon that we use. It's that education and practice needs to come together in a new nexus. And by doing so, it will improve the experience, outcomes, and costs in healthcare and education. So we call this the triple aim of alignment, that by redesigning together, you're improving the quality of experience for patients, families, communities, and learners at the same time. Sharing responsibility for health outcomes. So when students come into these environments, that they're actually intentionally working on outcomes for patients, and while improving education at the same time. And then reducing the cost and adding value, not just in healthcare, but also in education at the same time. So it is happening across the United States. It is remarkable what some of institutions and educational programs are doing. And we are working and engaging more and more people in helping with this redesign. So one of the AMA Accelerating Change in Medical Education recipients is Rutgers. And they are going to have deployed teams. All of their students are going to be formed in teams, and they're going to be taught quality improvement. They are going to be deployed in practice with the intentionality of making a difference in practice and collecting data. So again, this redesign and data is starting to go hand in hand. We, and I will send you our most recent, our annual report, which we're just finishing up. We've done quite a bit of publishing now. So we have developed, so we have a network of institutions. So there are some sites in Minnesota that has helped us to develop a comparative effectiveness model. So it's places like Medical University of South Carolina, University of Kentucky, Indiana, Pitt, University of Pittsburgh, and they have helped us design a strategy for collecting data about teams and how they're formed, what the process of care looks like, and what the educational programs look like. We collect data on ecological factors about such things as licensing, scopes of practice, and the like, and then connecting it to outcomes. Some of the projects are huge, some of the projects are small, and have been an entree to get into practices. So what we've done is we've really spent a lot of time publishing the approach. Just last night we had our first data coming out of something called the National Center Data Repository. And just last night we had a proof of concept paper that was accepted in a journal called Healthcare. So again, before this fast track study committee got started, we knew that we needed to do this, because I've been around too long and know that this type of education can go away just as quickly as it comes up if solid outcomes and data and working with leaders doesn't happen. So I'm going to just spend, and I think this is next week's.
Yes, that's
okay.
on 19th of November.
Okay. So next week, whenever the 19th of November is, Thursday. Oh my goodness, is it? November's just going by. So for about the last year, 8 months or so, Connie Schmitz has led a group with Brian Sick who's in the Office of Education leading the One Health curriculum, our interprofessional curriculum, which we've actually had up and running for a while. And they've spent a really long time engaging many programs, looking at what are the competencies that our students need to be, quote, quote, collaboration ready for practice. And what should those competencies be? And then what should be the strategies for assessment and research on it? And they have chosen, rather than the triple lane, to focus on something called the quadruple lane, which Tom Bodenheimer, who's a family physician at UCSF, University of California, San Francisco, talks about the fact, we're going through all this change, which is very stressful on health professionals. The fourth aim needs to be health and well-being of the provider. So they chose that this was a very important focus of the work, which then brings in programs like the Center for Spirituality and Healing. So they did a lot of vetting. They'll talk about it next week. They reformulated the FIPSI course this year based upon feedback that we have received, taking a look at a lot of the programming that's already done and how do we fit this thinking in. And they're starting to present as to what their recommendations are for research and evaluation of our own program. So again, this is a major opportunity in supporting faculty in scholarship and evaluation. That's really, we've got a framework, and I don't know of many places that have done this extensive of thinking about the framework and the research that's needed. So they have 3 assessment methodologies that are proposed, 3 areas. In simulation, work-based assessment. Am I stealing your thing? No, I'm warming them up, okay? Yeah. What I am very excited about is the knowledge testing. So that third hierarchy of knowledge and, is absolutely critical. So coming to consensus as an institution linked to what's needed in practice in our environment is a big deal. And so it will serve the field well to be thinking through this type of rigorous thinking about the framework and both the research strategies. So I'm going to stop there and actually open it up. We have 15 minutes or so, 10 minutes, and ask you for questions. Either about the report, anything about this area. Don't ask me a hard question.
I'm just curious what kind of reaction you've gotten to the Iowa report. What's the impact you think before you had it that you're going to come together again?
This is a great question. So we worked our buns off, and so we put a report out there. And in the IOM, I didn't talk about this, they actually have reviewers that review it and provide feedback. And then they have these people in the IOM that make sure you actually answered the question. And so one of our answers was there's no evidence. They had a really hard time with that, saying that we weren't answering the question. And so there was some back and forth. And Malcolm Cox actually had to step in and give with the report. That was the first thing. The second thing was, I'm sorry, it's fine. I'll stand here. I don't like it, but I will. The second thing was it was released on April the 22nd. And that was because the Global Forum was reconvening. So literally, we had the meeting in October, and 6 months later, we produced this report. They decided to send it out that morning, and we run in there thinking we're the whole afternoon discussing the report, and we were one topic on a very big schedule. And so they hadn't read it, and they literally looked at us like, what is this about? And many of them were like, thinking we were going to be promoting innovation and all that sort of thing. And so we had to keep taking them back to their charge to us. So if you're looking for innovation in this report, it's not here. And so it really needed to settle. So we went back in September, they had another meeting, and it's starting to settle in. The bottom line is, for most people, they haven't really thought through that this really needs a rigorous approach. It's so darn hard to just do it, period. But what we're finding in the National Center is we have this rigorous approach to helping people think this through, that it's really pushing people in a more rigorous direction. So I would say that the results of this are mixed, and we're actually still going out doing a lot of presentations. So we'll probably have one in Altogether Better Health. We just had one at the Collaborating Across Borders Conference. We put in our joint accreditation based upon this report. So I think it's going to take time for it to settle in. But again, this field, the understanding of it is so wide. As you know, you've read the literature. And so for the people that are ready for it, they are really embracing it and are ready to move on. For the people who are just having trouble getting people together to even do this education, they're still scratching their heads. Yes.
So this is the Holy Grail question. I mean, what would be the Holy Grail? And I mean, as I think about it, if you could prove a team achieves the triple aim to a greater extent than it needs to be provided
At a lower cost.
At a lower cost.
Yeah.
So that's what it is. I mean, how would you approach it? I mean, if you had the resources to design a study.
So we will do a presentation for you. And so the work that we're doing is just that. So we're teaching people how to think through in a specific area, let's say diabetes care is one of them, is, what are the outcomes you're trying to achieve in the triple aim? And then what's the formation of the team that you have and how are they educated? So we literally help people work through that and have 6 surveys that people are collecting data and uploading into a repository. And a piece of that is something that's very specific to that project. So this is the work that we're working on, and we believe that it needs to be a national model. But, again, read the book. And but there's many recommendations for study design for really taking a look at these outcomes.
We have an ongoing interprofessional grand round conflict at the VA. About 100 people us.
Yeah.
We're in our 3rd year. And the standard of continuing ed survey. How do we find people who would have the interest and ability to measure something more complex than, did the content meet your objective?
So you're saying, how do you put the teams together?
No, how do we find somebody to do the research that you're proposing being done?
And that's the team I'm talking about. So the interdisciplinary researchers. So again, it's going to take an investment. And so yesterday we were invited into one of our large health systems to present our approach. So again, we've put together the teams and putting together recommended models for how to do research in this area. But again, it's going to take people at your local site, and you have many of them in health services research, to stand back like Albert Wu as to how do we construct the research on the team formation to the outcomes to do the kind of research that needs to be done. You have many of these people there.
But I mean, yeah, and you may know them better than I do.
Mm-hmm.
So that's kind of the question: how can the center, kind of like the Speakers Bureau, the equivalent of the Research Bureau, is here are some people, whether it's locally or with your focus in research, that you might contact who, if you had funding, would come and do it.
Why don't you invite us in and we'll help you? Okay. So we did go into one system yesterday and present. Actually, Amy does it all the time. Amy works in a team. So we have a team of researchers, and then we have a team of data people who help to collect the data. So we have a standardized approach to this. Yeah. And we're actually developing, so we got into a foray of our first time doing a 4-hour workshop. We've only done it once, and we got really good response to it. You will see us start to teach methodologies now, because we've had to feel pretty comfortable ourselves that we're figuring this out. Not that it's the end all be all, but we can share with you what we think what the right approach is. You know, I'm looking at the new School of Dentistry is bringing up a pretty innovative clinic with pharmacy. So we're helping them think through how to collect data in that particular environment. So is that it? I know that doesn't answer your question.
No,
you wanted me to give you the magic bullet.
No,
Yeah.
you confirm that this is a problem.
It is,
You're
yeah.
developing a
Right.
methodology.
That's right.
Figure out how to do it.
That's right. Others?
Well, thank you very much.
Thank you.
We will be sending out a copy of the annual report and then also a flyer for our next session and then some other materials along with the evaluation. So thank you for attending.